Right, good afternoon and welcome to the HEE Foundation Programme Review webinar. Thanks very much for taking the time to come along this afternoon. We've put this webinar on to highlight the work that we've been doing with the Foundation Review and some of the things we've taken forward in order to support Foundation doctors in their training as much as we possibly can. We have a packed agenda with lots of things to talk about, and I'm pleased to say a number of different people to help us out this afternoon, who I'll introduce as we go along. There'll be a recording available of this webinar that will be on our YouTube channel in a few days' time, and you can see on the slide shown the sorts of things we'll be talking about: the review itself, self-development time, less than full-time training, the Foundation Charter, and of course it's very important that we hear from you, and so using Slido as shown, if you want to put forward any questions or comments, then please feel free to do so. So if you open the sly.do on your web browser and in the participant box enter #FoundationWebinar, and we'll try and cover as many of those questions as we possibly can over the afternoon. So in the first instance, I'm going to hand over to Tony Choules. Tony is a Foundation School Director in the West Midlands. I'm pleased to say he's recently taken on roles with the UKFPO as Operational Advisor and also as Faculty Development Advisor. But for this afternoon, I'm very grateful to Tony for all the work he did as Special Advisor to the Foundation Programme Review over a couple of years from 2018. And a lot of the work that we've done in the review was done itself by Tony and by Nick Spittle, and I'm very grateful to the two of them. So Tony's going to give us a brief overview of the Foundation Programme Review in total, and then we will come to some specific issues that we'd like to discuss. Thanks, Tony.
Thanks, Mike. I apologise that the next few slides are quite busy, but we just thought we'd put all the information down and you can certainly look at them later. The Foundation Review was announced towards the end of 2017 at DMEC, and as Mike said, I joined as an advisor along with Nick. The purpose of the Foundation Review, there were a number of reasons for looking at it. Not least of which was the Foundation last had a review sometime back in 2012, 2013, and changes were instituted 2015 or 16. So it's really to sort of review progress then. I should make it clear that the UK FPO is a four-nation organisation, and we have doctors across England, Ireland, Scotland and Wales. This review was actually conducted by HEE, but we did have significant input from all the nations involved with the programme. So next slide, please. What we did, it seems a very long time ago now, we conducted some literature reviews. We looked at the previous review of the programme, the Collins Review. We set up some stakeholder events with a variety of people involved with Foundation, NHS employers and doctors in training, doctors who've been through the programme, and Foundation supervisors. And gradually we formed it into sort of 5 working groups. Next slide, please. The groups worked away independently, but with a sort of oversight, and eventually we came to 16 recommendations, which nobody can remember numbers above 3 or possibly 5. So we condensed those down into 5 sort of groups of recommendations, 4 and 5 of which I'm going to group, well, numbers 4 and 5 I'm going to group together this afternoon. This report was actually published in July 2019, and when we talk about the sort of progress, that comes from a report that was published subsequently in July 2020. So one of the first and I think most important aspects of the review was looking at transitions both into foundation and out of foundation. I think we all know, and the review certainly highlighted, that transition from being a student to becoming a doctor is a fairly daunting time for most graduates, and we wanted to try and make that, I suppose, that transition as comfortable as possible. One of the things that has come out of it is the UK FPO is now working much more closely with Medical Schools Council to try and improve the process. One of the things that came out of the review, which I think we should be particularly pleased with, and the feedback's been very positive, is that we've set up a programme working with the Academy of Medical Royal Colleges to allow more senior trainees to buddy up foundation doctors, and we think that's a really good way of helping them to settle in. We've also published guidance on shadowing, and one of the things that we're discussing with the Medical Schools Council is how we can perhaps improve apprenticeships for students to make them more ready to enter into the foundation programme. Yeah, so there's various other progress around the transition, and one of the things that we've been looking at is the allocation to the foundation process. One thing that came out of the review that I think we're all coming to realise, and perhaps coming to realise across the medical profession, is different groups of doctors need different levels of support. Next slide, please. One of the groups that we were particularly tasked with looking at is doctors from a widening participation background who entered medical school through this process. And we know that many of them, in fact, most of them probably when they graduate, are completely indistinguishable from any other graduate. But there are some that still have difficulties. And one of the things that came out of the review was around the sort of financial support that they've had through medical school and the difficulties they may have in establishing into the foundation programme. So we looked at our pre-allocation process, used to be called special circumstances. We've renamed it pre-allocation, and we've looked at how doctors are allocated across the programme. And one of the things we've introduced as a result of the review is to support the widening participation doctors, giving them the opportunity to undergo pre-allocation either local to their medical school or near their home. There were other groups that also need support, and I'll talk about those a little bit later on. Next slide, please. One of the things that did come out of the review, and one of the reasons for the review, was the distribution of doctors around the country, and we know that there are areas of the country which are under-doctored. They're often in areas of deprivation, and we know that foundation doctors are allocated to them at the moment on a very meritocratic process, which the foundation doctors like, or certainly the ones that get the rotations that they're keen on. But it does, however, mean that there are other places around the country that are not easily filled by foundation doctors. And one of the things that we looked at was trying to make these places more attractive. And in particular, we developed some foundation programme priority programmes, which we hoped by offering incentives might encourage more people to attend to want to go to certain places around the country. As well as that, we had to think about the allocation of foundation doctors, the allocation of the new foundation doctors. You're probably aware that we're having 1,500 new doctors coming out of medical school over the next few years. And one of the purposes of the review was to look at how they might be placed. And we thought very carefully about the distribution of foundation doctors, and very soon the distribution is going to be announced. The priority programs have had an impact. We had a reasonable application to them the first year. They're now in their second year, and we're analysing that process at the moment. Next slide, please. Once they're in post, doctors also need some support, and one of the things that came out of the review was the Foundation Charter, which we'll be talking about in a little bit more detail later on. But this was really looking at how we could support doctors in their placements, how they could we could make their lives better. I think a lot of the things in the charter were things that we hoped might be done anyway, but we know that in some areas they're done less well than others. And we hope that by publishing the charter we might encourage better support for foundation doctors once in post. One of the things that's in the charter is self-development time. This is 2 hours for F1s and 2 hours for F2 a week to allow them to develop their portfolio competencies and other things that they need to do as part of their training. I mentioned earlier the idea of supporting widening participation doctors, and one of the things that we feel is important with the review is that it's not only getting the widening participation doctors into post, providing support for doctors who need it getting into post, it's providing better support once they're in post. Next slide, please. And that's really trying to improve educational support. We've done a number of things in that area. Mike's mentioned that I've now been appointed as faculty development advisor to the UKFPO, and we're starting to deliver webinars such as this to help, I suppose, upskill our educators. One of the things that we're very keen on is that educators who look after foundation doctors fully understand the needs that they have. These are very junior employees, they're very new to medicine, and many of them need some extra support that they may not be used to giving higher trainees. We're also developing more e-learning for health modules, and one of the things that I think is really important that we're doing is, I mentioned the widening participation group, but there are other groups who need the extra support as well, and these are doctors from other ethnic backgrounds, doctors covered by the Discrimination Act, doctors working less than full time, and in particular we know that doctors coming in from abroad, international medical graduates, need some extra support, and we're working at trying to raise awareness of this and develop resources to support them. Next slide, please. So just finally, before I finish this section, really, the HEE has commissioned the RSM. This is not the Royal Society of Medicine, but has commissioned the RSM to review the programme, or review the process of the review, and look at the impact it's had. So I'm going to move on to the final slide, which is just a summary of the things that we've achieved, and at the bottom some of the things that are still outstanding. I've already mentioned the need to develop support mechanisms for doctors from certain backgrounds, to continue to develop the e-learning for health resources, which links very nicely to our foundation curriculum. And I mentioned the transition at the beginning. I mentioned the transition into foundation. We still need to keep working at the transition out of foundation into specialty training. And I'm going to stop there and hand you back to Mike.
Thanks very much, Tony. a lovely summary of where we've got to the foundation program review, and I'm very grateful to everyone involved in the foundation program, people at trust level, educational supervisors and program directors, coordinators and administration people at trust level as well, of course, foundation school directors, foundation school managers, and other staff at local offices, and our colleagues at the UKFPO as well, for all their help in what we have achieved so far. So what we'd now like to do is drill down into three of those specific areas that Tony had mentioned, that we would like to take forward in terms of the foundation program review. And the first I'd like to concentrate on is self-development time, which has been something of a bone of contention, I think it's fair to say, since it was first mooted, but we believe is a really important way of showing our support for foundation doctors. It became very obvious during the working groups of the foundation program review that the curricular requirements that foundation program doctors needed to achieve in their e-portfolio was often a burden in terms of the time needed and the availability of their supervisors as well. And this was reflected by accounts from lots of foundation doctors were saying they had to do an awful lot of it in their own time because there was less time available during their working week. And whilst Tony and the Academy of Medical Royal College's Foundation Programme Committee have worked hard with the curriculum to reduce the burden of assessment, what we still want is our foundation doctors to be reflective practitioners who have the time to think about their practice and what they've learnt from the work that they've been doing. And so we wanted, as part of the foundation programme review, to think about how we could help them to do that. And one of the ideas that came up was to have some time in the working week for non-clinical professional activities that they're required to do in order to fulfill their curricular requirements. And so this was discussed with lots of key stakeholders, including some foundation schools, NHS employers, the BMA, and we came up with the concept of self-development time, which in itself has already undergone something of an iteration. The original foundation program review suggested that there should be a differential between F1 and F2, and so we piloted last year 1 hour per week for F1s and 3 hours per week for F2s, but it soon became apparent from the feedback from trainees and their supervisors that both sets of trainees needed some time. Next slide, please. So what we are moving to, as Tony has already mentioned, is that from this August, we would like to implement and have asked all foundation schools to ask their local education providers and trusts that all foundation doctors, F1s and F2s, should have 2 hours per week of self-development time. What should that be used for? Well, formal meetings that we ask them to do and should be documented within the foundation program e-portfolio with their supervisors, time for reflection on their clinical practice, their own career and development needs. And I do strongly believe, as is emphasised by the GMC, that reflection is a quality that all doctors should have, and being able to write it down, there is some good evidence that there is an added benefit to this, both in terms of the clarity of thinking that comes from that, and also having a record of reflection itself. But that, of course, does take some time. Other e-portfolio requirements, such as getting some SLEs done, could be used for self-development time. Preparing and delivery of teaching, which again is a curricular requirement both in the old and new curricula. Quality improvement projects. I believe that foundation program doctors are a fantastic resource to be able to improve the quality of care, but need to be given the time to in order to do this. So it's not just about a curricular requirement, but also something that's to the benefit of patients and the wider NHS. And then also, of course, some time to think about their future careers and how they may achieve that, which is a very important part of foundation program work. So as mentioned, we would like foundation doctors to have 2 hours per week on average. Feedback from the pilots we've done shows that this often works best when batched together, so perhaps 4 hours per fortnight, either as a morning or an afternoon, or even 8 hours as a whole day every 4 weeks. We're very happy for people to use their own local knowledge and variation on that, but we do believe that it's right that doctors get foundation doctors get those 2 hours per week on average for their self-development time. Next slide, please. Of course, it's also important that that self-development time is not used for other stuff. And so we've put a list here of the sorts of things that actually we don't think should be included in self-development time. Departmental and trust teaching programs, which should already be well established, and departmental or trust meetings. Study leave is completely separate to self-development time. It's really nothing to do with this at all, and we will cover a bit later about tasters, career tasters, but again probably should be part of study leave. Induction programs should be part of working time as part of contractual requirements, and likewise mandatory training. So there's just a few examples of what we don't want included in self-development time. It is there for our foundation doctors to be able to fulfill their curricular requirements, and they should be given every guidance in doing so. It's really important, we think, that at opening meetings with named clinical supervisors and educational supervisors, that the self-development time and how it will be achieved should be discussed. And further feedback from the pilots show that where it's rostered, so that it's included in rota arrangements, it's much more likely to happen and much more likely to be effective for the foundation program doctors. Where foundation doctors are told to go off and arrange it themselves, it's much less likely to happen. So we'd be really grateful for any assistance that trusts can give to their foundation program doctors in rostering them for their self-development time. And prior to the foundation program review, there were some really good examples of really good practice around the country, which you can find on our website as to how to make this work. So moving on, if you've got any questions about self-development time, please put it in the Slido, and we will try and cover that a bit later. One of the other very important aspects that was covered in the foundation program review was about less than full-time training, and more of our foundation doctors are making a request to do less than full-time training, and so we need to make it that they have the same quality of training and the same educational and support opportunities that other foundation doctors who are working full-time have. But in order to try and illustrate this, I'm delighted to say that we have 2 trainees who work less than full time who have agreed to come along and give their views of this, as they, of course, are much more in touch with what it's like to be a less than full time trainee in foundation program than I am. So I'm delighted to first of all introduce Dr. Fatima Junaid from the east of England, and Fatima is going to just give us a few thoughts on what it's like to be a less than full-time foundation doctor.
Thank you for inviting me. So I just thought I'd share my journey and explain my experiences and some thoughts on working less than full-time. Next, please. So I started my F1 and I worked full-time for the first rotation, so I did 4 months, and then I took 8 months of maternity leave. Next. And I came back into F1 again in August the following year, and I went back at 60%. I wanted to kind of ease into work more gently, and I was still heavily breastfeeding, and 60% felt appropriate. But after 8 months, I felt ready to kind of increase my hours. I wanted to speed up my training, gain more experience. So I went up to 80%, and I completed my F1 over 2 years. Next, please. And then I just stayed at that percentage, and I'm currently in my third rotation, F2, happily working at 80%, and I should finish my foundation training at the end of October this year and start specialty training in November. Next, so ways of making it work. I found my training to not have been impacted at all. I've developed my portfolio and my competency in line with my full-time colleagues. I found clinical teams very welcoming, and I've had no problems working less than full-time with any of the doctors or staff I've worked with. I've worked hard to make it work by making sure that the day I take off doesn't coincide with important clinical activities. So finding out when the teaching day is or when the kind of monthly clinical governance is, and making sure that I kind of minimize the commitments that I'm missing. And kind of around COVID times, outside of kind of pandemic, attending socials so that you're still very much part of the ward team. And actually, even at 60 or 80%, I found that well integrated into the team and didn't find it an issue. And I've been very grateful to my deanery that I've been allowed to change my percentage quite easily. The impression I had was I'd suggest a percentage that I'd like to do and they would find a way of making it work. And that really helped with finding a kind of work-life balance that worked best for my kind of situation in life at the time. Next. So the benefit is pretty obvious, work-life balance. This is my 2.5-year-old. I love being able to spend time with him. I have Monday off every week that is just me and him, and to be able to have an actual kind of solid part of his childhood and see him grow up means a lot to me. Just last weekend, I didn't see him for 72 hours because of long shifts, and that's fine. I enjoy my work, but to know that every single week I have a dedicated slot for him has done wonders for me, and I find invaluable. Next. I do find there's two challenges. The first is one that actually all trainees have, but I think is exacerbated in less than full time, which is the logistics of going through foundation training. So information on rotas not being given in time or placements. And because we have more placements, and because actually it's very important which day the teaching day is, not getting that information soon enough can be quite stressful, and means that there's delays in rearranging childcare. The second challenge, which is specific to less than full time, something I feel very strongly about, is the idea that once I went out of program on maternity leave, I then lost my subsequent rotations. When I started foundation training, I was in the top 10 of my deanery. I did very well in my application. I was able to pick where I wanted to go and what specialties I wanted to do based on my career aspirations. So it was a bit of a shock when I came back the following August to F1, and I had no pick of specialties and I had no pick of location. And indeed, I was placed somewhere that was a 3-hour round trip per day from where my husband and son were. And that was quite a stark contrast, and felt deeply unfair that kind of post that we'd won an open competition, suddenly kind of lost all that kind of choice. And I would say my deanery did work very hard for me. Like, the people involved did try and make things work. And actually, with a lot of negotiation, both in my F1 and my following F2 year, we did find a solution for me. But I think it's something more to do with the system rather than the people, because it is quite tricky. And I think that's something that really needs to be addressed, to be more fair to less than full-time trainees, who I don't expect to be given preferential treatment, but I do expect to be kind of treated equally with other people who are able to compete for their posts. But despite those quite significant challenges and stresses, I would absolutely do it again. I love working less than full time. I love that time I get to spend with my son and see him grow up. And I'm very grateful that it's an opportunity and relatively easy for the deanery to kind of facilitate. So thank you for that.
Thanks, Fatima. That's very nice summary and a lovely picture of your son. Nice to see him. So I'm just going to ask you, you know, just just clarify a few little things and get your thoughts on them. During your maternity leave, first of all, did you keep in touch with the your foundation program director or educational supervisor or people, or and what was the sort of lead-in time that you needed to get all of your less than full-time training organized before you started at that point?
So I didn't do too much of the keeping in touch days, just because I knew I was coming back in August, and actually I went through the F1 shadowing process like everyone else again. So because that was reintroducing me to clinical practice, I didn't actually do the keeping in touch days. And so yeah, I had less of a link with my educational supervisors. In terms of the lead-in time, I think I approached my deanery 3 months beforehand, and that was fine to sort things out. Again, because I tried to negotiate which specialties I wanted to choose. It did mean that my allocation was delayed somewhat, but I chose for that to happen because I didn't want the first choice that was given to me.
And I think that's a really important message for both sides, I think, isn't it? The sooner that you start the conversation about going less than full time, the easier it is to get those things organised. And
yes.
and as you say, contacting them 3 months beforehand gives people time to sort those things out, and for you to sort yourself out in terms of what you need to do in terms of childcare or whatever it is. Yeah. Okay, and you mentioned Fatima, teaching programs, and that you sort of try and get to those all the time. What do you think? Many people would now say, well, teaching programs are often recorded, and why can't people just go and watch a video or something like that? What do you think the benefits are for you as a less than full-time trainee of getting to those teaching programs?
So even though during COVID we've had a lot of online teaching, and that means a lot more people can attend them, I'm a very big advocate for doing things in person where possible. And I know that in our own trust they are returning to some more face-to-face teaching, because you have that time to speak with your other trainees, to share ideas, to share experiences. So from that perspective, a recorded video is subpar to a face-to-face event. And also, even if it is only a recorded option, I have to then find other time to do that, and I can't do it on the day that I'm with my son because he'll take up all my time. So I think it adds another layer of stress of, okay, when am I going to fit that in? So a possibility, and it works for some people, but not one that I would want to pursue.
So the contact with your trainee colleagues is a really important part of that teaching, and and that's what we might lose if everything went virtual, isn't it? Yeah. And another thing I've heard from less than full-time trainees before is that there can be some anxiety around sort of handover of patients on the days you're not going to be there, and how you ensure you keep yourself up to date with what's going on with the patients that you've been looking after when you come back to work after your day off, in your case. Any thoughts or tips on how trainees can deal with that?
I think our current training prepares you for that anyway, because there are so many, the rotas are fragmented. You need to have good handover anyway, even if you're working full time. So from that perspective, I don't feel disadvantaged or that I need to do anything differently. I just need to be very good in my handover and very good in being able to kind of pick up what other people are doing. So I think it's kind of the nature of medicine anyway, that things are fragmented regardless. We go from one ward to the next.
Okay, and any tips for supervisors who may be watching in terms of how they can help trainees in less than full time? What is your educational and named clinical supervisors? What have they done well that have helped you to get through training, do you think?
I think picking up on making sure you're progressing in the right direction, but also and at the rate that you need to be, but also looking at your career aspirations longer term. It might be easy. I think the first couple of rotations, I was just trying to get back into clinical things, and I kind of forgot about the broader aspects of my portfolio and developing myself. And having a supervisor who's like, okay, what are you doing in this aspect? What are you doing in terms of clinical improvement? Kind of gently kind of poking you in the right direction is helpful.
Okay, and in terms of curricular requirements, Fatima, how did you, some of the sort of more specific things like doing a QI project or getting a teaching observation, these sorts of things. How did you get those done when you're not in the workplace as much as some of your colleagues?
I think it's about being organised. Like I say, I've completed my curriculum requirements as a full-time person anyway, just because I'm very aware right from the start of my rotation what I need to get signed off, and making sure that happens means it's much less stressful towards the end. So I think just being well prepared, finding opportunities because there are plenty, and just being organised with it. Okay.
Well, thanks very much indeed for your time, Fatima. Great presentation, really clear, really great to know that you've been a successful foundation doctor as a really good example for lots of others who may want to work less than full time. And we all wish you the best of luck as you get, first of all, with your ARCP later this year, but of course, as you go on in a successful career. So best of luck to you.
Hello, everyone. So I'm a foundation doctor based at Torbay Hospital in South Devon. I've been less than full-time since the start of F1 in 2019, and I'm expecting my foundation training to take another 14 months or so. I'm also the BMA less than full-time rep for Peninsula. I'm really grateful to be here to have the opportunity to talk to you all, and I'm hoping to be open and honest about what it's really like to be a part-time foundation doctor. Next slide, please. So as a bit of background, this is me. I'm currently 33, so a bit older than the wider foundation doctor cohort. I came to medicine as a mature student. I used to work in the management of children's homes up in Manchester and Blackpool. I hadn't been to university before, and I took the brave step of enrolling at medical school with a 9-month-old baby. He's 9 years old now and very settled, living here in Devon. For those of you that know the area or come on holiday here, at the top picture, that's in Haytor up on Dartmoor. The second picture is near where we live. That's Elbury Cove between Paynton and Brixham, and that's my other half in the corner there. Next slide, please. I thought I'd briefly mention university, since the foundation programme's all about that transition from student to doctor. I was at St George's in London, which incidentally has a very large student parent community, but I found medical school really tough. I was a young mum with a young child, and I think I'd underestimated just how many hours of my week could be spent in lectures, placements, endless revision. And I had to work part-time to pay for London childcare rates. It was really tough. So I knew very early on that I'd want to work part-time in this profession. And actually that photo there of the birthday party, those are children of, well, then they were all medical students who all went on to be less than full-time foundation doctors, based in different places around the country. Next slide, please. And actually, less than full-time has been fantastic. I'm still learning to balance everything, but I don't feel burnt out anymore. At my trust, the average full-time rota is 48 hours a week, and we all know that that's topped up with needing to stay late, needing to complete QI projects, revising for exams, and I know improvements are being made with exception reporting and self-development time, but it isn't the sort of work life that I wanted or that I think I could have managed. So I currently do 2 or 3 shifts a week of my training time, and I supplement that with locum work at times that fit around childcare. So I do just under 37 hours a week. And I know in most jobs 37 hours isn't part-time at all, but for a job as a junior doctor, it just gives me a bit of breathing space to be a mum as well. So I was asked to talk about what I think the advantages of less than full-time training are. So these are the top 3. Better work-life balance. I don't think this one really needs explaining. So I'll focus on the other 2, which I hadn't really thought about when I put in my application. So work stability. It's rubbish having a job where you're still learning what to do. And on top of that, you have to keep rotating every 4 months. So it's great to be able to spend a few years at the same trust where most of the staff know you. I'm at a small DGH, and you get to learn the systems. And I actually spent an extended time in my first rotation. It was meant to be 8 months, but because of COVID, it was an 11-month rotation. And it was the most terrific start to my career. I wasn't wasting days learning new door codes. I was really able to get stuck in and learn medicine. And because I'm at my trust for 3 years, I'm really invested in improving the experience for myself and other trainees. I have a great relationship with our med-ed team, and I get involved with lots of projects at the hospital. So I think that's beneficial for everyone. And what I really wasn't expecting was a competitive portfolio. So at the end of F1, I'd already sat the first 2 parts of the MRCP exam. And I think that was just because I had the bandwidth to think about long-term goals, to revise. I'm often invited to get involved in projects, research projects, teaching projects. And I think that's just because I'm there for a few years. The consultants know that I'll be around to see projects through. I'm involved as a rep for lots of committees, locally and nationally. So that's been really great and really positive. Next slide, please. In terms of the downsides of less than full-time, these are the 3 that impact me the most, I think. So firstly, my days off aren't fully protected. I think there's an assumption that my days off are completely work-free, and it isn't the case. Teaching, meetings, they're often scheduled on my days off. And perhaps most impactfully, things like rotas and generic work schedules are often incorrect or very delayed, and I spend a lot of my time off trying to chase these things, trying to create rotas that work for the department, that sort of thing. Secondly, the pay. So it's public knowledge that the hourly salary of a foundation doctor isn't very high. So receiving a part-time pay slip can be particularly heart-crushing after a stressful week. My pay is low enough that I've been entitled to universal credit throughout my foundation training. And the reason this is important to know is just to appreciate the difficulty in having affordable, flexible childcare in place. And also the impact of delayed rotas and correct pay. If you've had contact with the benefit systems before, you'll know that, if there's any inconsistencies or inaccuracies in the paperwork, they'll put sanctions and just stop your income whilst it's being looked into. So, at the start of my training in particular, I had to go to the job centre quite a lot just to prove my hours and things like that during my days off. So it's just being aware of the impact of that. And the third biggest disadvantage for me is flexibility, which I feel is a bit of a double-edged sword. So yes, I have an extra day off a week and I love that. But for that privilege, I have to be very flexible with the trust and with the foundation school as well. I don't have my original rotations anymore. In fact, my rotations were only confirmed quite recently. So I didn't have any idea of how my training might look for F2. I didn't have the opportunity to swap rotations. And it's always difficult, I think, not just for me, but for everyone involved to be training out of sync. Next slide, please. I'll just finish by saying, that being able to train on a part-time basis has made the early stages of this profession enjoyable and worthwhile to me. I very recently set up a less than full-time foundation trainee network in the peninsula. There are 12 of us here. And despite all the grumbles, I sent out a survey last week and everyone said that they strongly agree with the statement that less than full-time has made a positive impact to their lives. We know that there's an administrative burden with having less than full-time trainees, but actually I think we can be a real asset to the workplace. We're adaptable, we're rounded trainees. I think we're generally happier too. And I think it's right that we're looking at this becoming the future of medical training. Thank you very much.
next step is to hand over again to Tony, who's going to talk about the Foundation Programme Charter, and perhaps publicise this a bit more, so that foundation schools and trusts can use it as a way of trying to improve training. Tony.
Thank you, Mike. Yeah, so the charter came out a year after the review. In that second document, the supporting one that provided some of the resources, and the charter was developed by my colleague Nick Spittle, who was the other advisor on the review, and it was so we consulted quite widely as we were doing the review. And one of the things that we did certainly in developing this was to speak to employers about the needs of foundation doctors, as well as thinking about the doctors themselves. We grouped the charter into three sort of main areas of support for the foundation doctor, and that was sort of ensuring safe and effective care, creating a supportive environment, and improving the educational experience. And you can see this, those of you who are familiar with the GMC guidance on developing a sort of supportive environment will perhaps see that there are some parallels there. If we could have the next slide, please. So I'm just going to sort of talk through the different standards and just highlight a few things in them. I mean, high quality induction speaks for itself. You know, if you tell your new employees what you want them to do, they're more likely to be able to do it. And we know that while some inductions are extremely good, you know, you'll be aware that sometimes foundation trainees are unable to attend induction, or they're very limited, or perhaps the material's out of date. And we think this is something that's really important that trusts need to be aware of. The next thing was staff being familiar with the level of training of foundation doctors. These are, you know, people who are new to practice. They have very, very limited experience, and they need support, and that leads into the next part of workplace supervision. You know, it should be fundamental that all foundation doctors have a senior doctor who they can go to for advice, or who can, you know, come and support them physically if needed. Part of safe practice is good out of hours working, you know, and we would expect good handovers for our foundation doctors, you know, supervised by people who can make, well, I suppose of decision-making grade, who understand the importance of handover. And then when they're getting out of hours, the kind of support or foundation doctors having the kind of support that they need, either via a hospital at night type system, and ensuring that they are well supported in their practice through the night, getting some chance to rest in between tasks sometimes, and you know, having plenty of support for what they're doing, and that comes into daytime tasks as well. You know, there should be perhaps phlebotomists on site, or other staff who are able to do procedures, so that the foundation doctor isn't constantly doing sort of a task-based approach to care. Standardization of equipment, I mean, that comes into human factors really, doesn't it? If you lay all your wards out the same, if your foundation doctors are moving from one to the other, you know, they can find everything, and I think more and more trusts are working in that line. Next slide, please. So getting on to the sort of supporting environment, you know, making good use of technology, you know, eye bleeps and such things, so that doctors don't spend half their time answering their bleeps. You know, facilitation of rest periods, and the opportunity to have food available 24 hours a day. If you expect your staff to work 24 hours a day, you should be able to provide some sort of resources for them, and quiet areas for them to rest in between. We all need a rest at some point during longer shifts. I've already mentioned the near peer support. This is something that Mike has developed with the Academy of Medical Royal Colleges and come out with some guidance. There are some very good near peer support systems running around the country already, and we're not out to change those, but we are out to flag up the importance and to provide a model of how it can be done. And really, I think this is one of the most important sort of things perhaps so far that's come out of the review, this idea of providing some sort of close sort of buddying, near peer support for new doctors coming in. Many of them, you know, they don't know their way around the trust. They're in a different part of the country from what they're familiar with. They don't particularly want to go and ask the consultant where the mess is, but having somebody to sort of show them where things are and perhaps just knows the local area, I think it's really, really important just to sort of ease them in. Next slide, please. I should say that there is an example available of the near peer support, and that should be available, I would hope, very soon from the UKFPO website. So improving the educational experience. Well, I've mentioned before that education and clinical supervisors need to be familiar with the needs of foundation doctors. One of the things that we became very aware of during the review was that the requirement to be a supervisor or a clinical or educational supervisor, there's a GMC guidance of what they're required to do. Many of them have trained as supervisors for their specialty and not necessarily for foundation. And I would say that foundation doctors do have slightly different needs from higher specialty trainees, and the supervisors looking after them need to know about these, and they need to know the requirements of foundation doctors. They need to be familiar with the curriculum, and they need to have time to work with their foundation doctors to help them to develop. We've already covered the self-development time, so I'm not going to spend anything extra on that. Next one is repetitive tasks. I mean, this partly covers with support for tasks, but just to put in a plug for the new curriculum, which is coming in August, one of the things it states is that foundation doctors' work really should, as far as possible, be patient-based and not task-based, so that they understand the process of care, not just learning the small fragments of it. The educational programme, we would expect to see educational programmes that reflect the curriculum, and in fact the new curriculum has specific requirements of what should be taught in some of the core teaching for foundation doctors, and part of that is simulation-based training. We in the review felt that all foundation doctors should have the opportunity to do simulation-based training. Been numerous reports coming out about how effective it is in training our junior workforce, and in fact even in maintaining consultant skills. So I think it's really important, and we recommend 3 sessions a year for each foundation doctor. And just going back to the curriculum for one final time, the curriculum actually states what some of these sessions should be to ensure a broad coverage, and that's just based on what is characteristically done in foundation schools around the country. So next slide, please. So we've given a list of, I won't say demands, but things that we feel are really, really important to provide for foundation doctors, and part of the document then gives you some suggestions to allow education providers to benchmark themselves against where they might like to be. We like to think that all education providers would like to be in the excellent category, but we give examples for these areas of practice, and things that we would expect as a minimum standard for upholding them, and then levels to aspire to. And I think what we'd really like to see is people going away from this webinar looking at what we consider the model of excellence and saying, well, we can work towards that, but perhaps with some quick wins, we can move ourselves from baseline to good. I'd like to think that there's nobody here who are below the expected values, but you know, you may find some areas, or there may be some areas in the trust that perhaps aren't quite up to that standard, you know, and maybe this document and some of the guidance will give you some, I suppose, support to move things forward and perhaps help them to develop and provide examples of good practice. So I'm going to stop there and hand you back to Mike. Thank you.
Thanks, Tony. Thanks, Tony. And again, I would really reiterate, please use our good practice guidance at trust level. As Tony has said, if there are some departments who you feel the foundation program training could be improved, or areas of your hospital or trust, then this gives you a framework for a discussion with those places and the people within them as to how we can look to improve training. It's actually my belief that I don't think anyone gets up in the morning and thinks, today we're going to give some really rubbish training. We fully appreciate that it happens due to a whole variety of factors, not least workload and service pressures, but hopefully this will give you start somewhere to start that conversation with people about how you can improve the lot of foundation program doctors. And we fully appreciate that these things don't change overnight. Both Tony and I are practicing clinicians, consultants in our own specialties, and we fully appreciate the pressures that everyone's under, which have been particularly highlighted, of course, over the last year and a bit. But nonetheless, we really want to work to improve foundation program training, which was the remit of the foundation program review, and so we would really recommend that you use the good practice guidance at a trust level. Perhaps if you're in a foundation school, looking at the trusts in your area to try and drive good practice. So thanks, Tony. That was really very helpful. I'm pleased to say that either later on this week or very early next week, the foundation program will have its own web pages within the HEE website, where the foundation program charter will be published. I'm afraid it won't be on sort of parchment like the Magna Carta, but it will be published as a specific document for you to use, and likewise the good practice guidance, also stuff about self-development time and other things that we've done in the foundation program review. So we'll be sending that link out to foundation schools to send on to their various faculty, and please use those pages as much as will help you. So we unfortunately couldn't get the other trainee to join due to technical difficulties, unfortunately. So we'll move on to the questions and answers. We did go out and see were there any particular questions that were asked beforehand, and then we've also got some questions from the Slido. So I would say that whilst I'm talking, if you do have any burning comments or questions that you'd like to ask, please put it into the Slido and we'll do our best to ask them. One of the questions that was asked was before the webinar was about career tasters, and so we have this guidance that was available on the UK FPO website, and hopefully this will answer any questions that you have about tasters. It is important to acknowledge that experience within a specialty is a quite important influence on what careers doctors want to take up in the future. And of course there's a huge range of different specialties that doctors can undertake careers in, some of which they may have jobs in the foundation program or have been exposed to at medical school, but others, particularly smaller specialties, that they may not have had that opportunity. And so we would like to give foundation doctors, where it's appropriate, an opportunity to undertake a short period of time where they get some experience within that specialty, and whilst these are not absolutely hard and fast rules, and that the use of taster weeks is individual to the foundation school and should be discussed with your local foundation school director, just a few principles that we think it's a reasonable time to take is between 2 and 5 days, and in most places that is taken out of study leave for the foundation doctor. If in many places where an F1 doctor wants to do a taster, they can sort of take back some study leave from F2, and that seems to work quite well. It's really important that during a taster week the foundation doctor isn't part of the service. They're not there to provide service. They're there to see what the specialty is all about. And in my opinion, a taster week should be spent with a senior doctor. So it should be spent with somebody at sort of consultant level or equivalent thereof, because the majority of our careers are spent as senior doctors, whether that's in primary or secondary care, and therefore it's important to get some insights into what that is like, as opposed to the relatively short period of time that one spends as a trainee in that specialty. So it's really, remember that the taster is about getting insight into what a specialty is about in order to help make a career decision. In most cases, a taster week should be taken within the same local education provider, but in smaller specialties, it may be necessary for it to be taken elsewhere. But again, one would expect this to be discussed with the foundation school director, and that is planned appropriately. Certainly in when I was foundation school director in Wessex, I wouldn't let anyone take a taster in a specialty in which they were doing a post. I don't think that's appropriate. It is a use of study leave, and study leave can be used better, and it's not extra leave. It is time spent as part of study leave. But I think the important principle is that we should be supportive of foundation doctors where they want to do a taster in a specialty in which they don't have a post. It's not at all a failure that they do a taster and then come out of it and say, you know, I don't want to do that specialty, because it's better finding out now than in a few years' time when they're undertaking training. I always ask trainees to do a piece of reflective writing about their careers taster, so that we can get some crystallise their thinking about it. And as we said, I've always gone between 2 and 5 days. So if any of your trainees want to do a taster and you're not quite sure what to do, please contact your local foundation school director or foundation school manager, and they should be able to help you with the local rules about that. Before we go on to the Slido questions, there was another question about birthday leave, which at the time I thought, gosh, that sounds terribly enticing, but I'm not sure is a thing. I have now realised what that is about, in as much as some trusts are saying, as a thank you for work during COVID, that you can have an extra day off, perhaps on your birthday. That is a local decision to be made by the trust. It's not in the national terms and conditions, and is not something that we can arrange either as HEE or the UKFPO. But if a local trust chooses to do that, then that is the best we can. The best we can say is that needs to be with the local trust. Okay, so we're going to go on to some of the questions from the Slido now. And first of all, I'd like Tony just to briefly touch on the new curriculum, which he's already mentioned, which is a very important part of our work over the next year. The question was, would it be possible to circulate a copy of the new curriculum? But Tony, perhaps if you'd just like to, make a few points that you'd like to about the new curriculum, because Tony has led the committee that has developed the curriculum. I think it's absolutely brilliant, and I'm so chuffed that we've got it out there. I think it's a really great piece of work, very appropriate for the 21st century doctor. But Tony, perhaps if you would like to say about a little bit about the curriculum and how it will be disseminated, that would be really helpful. Thanks.
Sure. Yeah. I mean, the new curriculum should be available for everybody in about a fortnight. It has been rolled out. All your foundation school directors have all seen the final drafts and all have had endless talks from me about how it should be run. So yes, we'll get to see it soon. I mean, I think the key points of the curriculum are we've gone for 3 areas of practice to make it easier to remember and to work, and that's the doctor as the clinician, the doctor as the member of the healthcare team, and the doctor as the professional. And I like to think that that's a very sort of clear 3 strands of medical practice, and not surprisingly, we haven't changed much about the idea of them going through probably 3 placements in each year, and a lot of their training and assessment being done on the shop floor. One of the things that we have done is we've done away with any numbers of assessments that need to be done, and because we've gone for the 3 main areas of practice, clinician, healthcare worker and professional, then we're asking them to provide evidence in each of those areas. We've cut down the number of professional capabilities to 13, and so the whole thrust of the doctor or the foundation doctor making progress as they go through the curriculum, as they go through the year, will simply be to add things into the relevant bit of the curriculum, and we'll look at them there. We won't be counting numbers and then asking them to link things through separately. It will all be done in one go. I mean, I think that's sort of the main thing. We have a couple of other perhaps things that we need to remember. Multi-source feedback is going to stay in there, and we're also trying to encourage people to use the placement supervision group more. So this is the professionals who look at the doctor's practice and support them through each placement, and then provide feedback to the clinical supervisor, which I hope will give a much fairer assessment of how the doctors perform through the entire placement, rather than coming down potentially to one individual making a comment. And the final thing that I will flag up is about the summary narrative. Any of you out there who are senior doctors will remember that every year when we do our appraisals, we write a little bit of reflection in the 4 areas of good medical practice for what we've done to show that we're good practicing doctors. And we've introduced a similar thing for the foundation doctors. This will be in their 3 areas of practice: the clinician, the healthcare worker and the professional, and just asking them to write a little summary of how they feel they've performed against those areas of requirement in the curriculum, and why they've chosen some of the evidence that they have done to put forward to their educational supervisor and the ARCP panel. So all will be revealed in about a fortnight. It's not a secret. We have shared other copies of the curriculum, but as I say, we're almost there with the final product, so it will come out to you along with some guidance on how it should be instituted, and the process for that, just as Mike asked me to talk a little bit about that, is that the curriculum will be shared round. I'm recording a podcast tomorrow sort of explaining the process. Foundation school directors and any curriculum champions for each foundation school will be sent this slide set. They can use my podcast if they want to, or they can deliver the slide talk themselves. That will cascade down to the FTPDs in each LEP or each trust or each hospital, depending on which nation you're in, and then the FTPDs will be able to cascade it to their educational supervisors. I'm very much hoping we will have a national webinar where we can do a similar thing for people that want to come into that. And I would add that there's a similar process going on among the trainee doctors. We have 2 excellent UKFPO clinical fellows in their F2 year who've been very involved in the development of the curriculum. And one of them in particular will be recording a webinar, has already delivered this to a group of foundation doctor reps. And again, we're hoping to have a webinar and a rollout process so that all the current F1s will know about the new curriculum when they move across to it in August. I think that will probably do. I'll hand you back to Mike.
Lovely, Tony. Thank you very much, and well done on your work on the curriculum. So we've had a couple of questions about tasters, and that slide is currently up there. First of all, it says, is there any guidance available on careers tasters? Well, what we've got on the slide there is the guidance that's available, and I can only reiterate that it is something that is negotiated with the foundation school or local office, but the guidance that we've got there in the slide is I think available on the UKFPO website. I'll go and check that, and we'll try and make sure that is the case. But it is only guidance. There are no hard and fast rules in terms of what is available. The other question is should we support tasters when we know the trainee has no interest in that career, as it feels like trying to get out of where they're working for a few days? Well, I mean, it's sad to hear that trainees may take that approach if that is the case. I think the question you have to ask is, how do you know the trainee has no interest in that career? I think if they are really clear they're just trying to get out of work, then that is a significantly unprofessional attitude that I would not take very kindly to. But as I say, I don't think it's a failure of a taster if someone does it and then finds actually that career isn't necessarily for them. I think I would want to explore that trainee's attitude towards their taster and what they're trying to get out of it. And certainly in the past, when I was a foundation program director at our trust, where people did want to do tasters, I did get them to write a little bit down about why that should be, what they wanted to get out of it, who they were going to spend some time with, and why. And where I didn't feel it was appropriate, I'd have a discussion with the trainee and come to some sort of compromise. So I think the next step there is talking to that trainee and seeing what their motivation is around doing the taster and why that may be. And of course, a good proportion of our trainees know exactly what they want to do in their career. At the other end of the spectrum, a very good proportion of our trainees have absolutely no idea what they want to do in their career, and that's absolutely fine at their stage, as they are so early in their medical training. And there's some who may have some thoughts but are not quite sure, and that is the point of the taster sessions. But I think if it is really clear that the trainee is just trying to pull a fast one, then I think that needs discussion with your foundation school director. But be really clear that that is the case and that there's not something else going on. So that was tasters. Tony, a couple of questions about less than full-time trainees. Perhaps if I could just ask you for your views on this and how you handle it in your school. One of the questions is, what more can be done to support less than full-time trainees whose allocated posts or trusts don't resemble their initial choices, and that childcare in particular can be a bit of an issue. Any thoughts about how you handle the allocation of foundation program doctors who want to work less than full time, and where they go and how you manage that?
Yeah, this hit us a bit hard a couple of years ago. We used to have split programs in the West Midlands where you chose your F1 rotation, and then partway through that you chose your F2 rotation. So we had quite a lot of flexibility in supporting our less than full-time doctors. And then when we went over to 2-year programs, we suddenly found that we were running into difficulty because when the less than full-time doctor dropped out, obviously the F2 post ended up getting filled, and then we were having to look 2 years ahead, maybe 3 years ahead for the F2. I mean, my view is if we get enough notice, personally, I will do my very best to get them back into the programme that they want to. The difficulty we sometimes have is we're not quite sure when trainees coming back. So I mean, if as Fatima said very sort of elegantly, well, I decided I was going to take 8 months out, that fitted very nicely around the programme. You know, it fits in with our time scale as well. You know, if the post was available, I'd like to think we'd be able to do it. But of course, what we have to remember is that, you know, there's another cohort of trainees coming in who are looking at programs, who are requesting certain programs and ranking them and so on. But, you know, as I say, I think I'd be very sympathetic. In fact, I'm very sympathetic when less than full-time doctors say, well, I'm coming back at this time, you know, can I earmark that program? You know, and I think they should, personally, I think they should be able to get back into, as near as possible, you know, the program that they left. Sometimes it's not practical, you know, times change, programs change, and that makes it more difficult. But I think that the message is, you know, try and be as clear as possible with your foundation school about when you're coming back, or when you want to change, and what I suppose what you want to do. I suppose I've strayed a little. I've just realised into the thought of sort of maternity leave and coming back into foundation. I mean, one of the difficulties we have when people go part-time through a year, you know, for other reasons, perfectly legitimate health reasons, and then it can be very difficult. But as I say, if the rotation is available, then I'd be very keen to allow trainees to carry on in it. The difficulty comes when that rotation's already been given to somebody else. There are some schools, I think, that have more supernumerary funding for less than full-time doctors. In our school, what we would do is we put a less than full-time doctor into a full-time post. If they can find someone to share with, that's great, but otherwise the trust get the top up for the funding and then fill the other part of the slot however they choose to. And so it does depend a little bit on the model out there.
And another question, Tony, less than full-time, interested in your views. It says, with regards to foundation doctors working less than full-time, how does this marry with recruitment to specialty programs, which may have limited application and start day windows? I guess there's probably not much that we can do about that in foundation, really, is there?
There's not. I personally have a view that other, you know, specialties should be a bit more flexible, but you know, obviously that's not within my gift. You know, I suppose, you know, Fatima clearly approached this in a very, you know, sort of prospective way and thought, you know, when do I need to finish? Could I do a bit of extra time here to ensure that I fulfill the requirements as I go through? And I think that's probably the way through. I mean, I think we should bear in mind that 70% of foundation doctors don't go straight into specialty training, you know, and sort of may spend a year or 6 months or whatever out of program. So, you know, I think there are some who presumably want a very sort of fast track career, but, you know, if you come out of a less than full-time program, out of phase with everybody else, you know, there are an awful lot of posts around that the doctor could work in to develop skills or even have some time off before, you know, moving into specialty training.
Thanks, Tony. Moving on to a different subject, we've had a few questions about self-development time, and I'll take these and first of all I'll read them out and then give you thoughts. First of all, there was one about, would it be acceptable for the trainees to sandwich their leave around their SDT, to extend their leave by a further day? There was a question about how much SDT, self-development time, has to be given to less than full-time foundation doctors, and whether self-development time should be given for 52 weeks of the year or the 44-ish weeks that they would be expected to be at work. Well, I think the key bit there is the last bit, that self-development time is work. It may be non-clinical work or it may be work that's not done in the clinical environment, but nonetheless, if we can get our heads around that self-development time is part of work, it's not extra leave, it's not something that you know, is sort of optional, it's not something that the trainee can do whatever they want in. It is time that we would work time that will be used to fulfill their curricular and e-portfolio requirements. So if we conceptualize it as work, then in answer to that, is it 52 weeks of the year or 44 each? Well, it'll be 44 weeks because that's how much work they do. If it's or however long it is that you think of as them doing work. If it's around less than full-time foundation doctors, it's pro rata to the work that is done. Is it acceptable for the trainees to sandwich their leave around to extend their leave? Well, it's not more leave because it's work. We wouldn't just say, well, you've got leave booked on a Wednesday and a Friday, so therefore you can just have Thursday off as well. You would be expected to come back to work on the Thursday. I hope that makes sense. But I think if we start thinking of self-development time as being work, then a lot of the answers to those questions become a bit clearer. It's something that I hope will be well received by foundation doctors, and certainly in the pilots where it did happen was well received, and they found it extremely useful. But I did hear anecdotal stories of foundation doctors asking if they could have their self-development, a couple of hours, if I could have it first thing in the morning so I can have a bit of a lie-in. I don't think we would allow them, to come to a ward round late so they could have a bit of a lie-in. It is work. Self-development time is work, and should be within the work patterns and agreements that junior doctors should be having as part of their contract, and should be recognised as such. So I hope that's helpful in how you think about self-development time and its organisation. It's something that obviously we really support it. We really want it to work well for junior doctors, and we do feel it would be really in the best interest of their wider and professional development that they have that time. But nonetheless, it must be spent doing something to do with their own development time, and not something that is just extra time off. It's not that at all. Tony, I think this is a question of clarification about less than full time. If the foundation doctor works less than full time, does the trust receive money to staff their absence? Don't understand the logistics. So perhaps if you could just explain what you meant by that.
It depends which foundation school you're in. The way the West Midlands does it is they put a less than full-time doctor in a full-time post. They give the trust the full funding for that training. And therefore the trust can use that money to backfill the post. There are other areas that would do it in different ways, and some will only pay for that the time that doctor is in training. In those areas, they very much tend to put two doctors in job sharing rather than leaving a post vacant. There are pros and cons to different ways, but one of the advantages, I suppose, of the way we do it is that the trainee can choose to work anywhere between 50% and 80%, and really, it doesn't really matter what they choose. In other areas, if you've got doctors job sharing, they're pretty much limited to 50 or 60%.
Thanks, Tony. Another question's come up further to the self-development time. Has anyone taken any action where it's clear the SDT has been given but not used appropriately? To be honest, I'm not aware that anyone's had to take any action. I'd like to think we won't have to if we are really clear with everyone involved. So that is from a foundation school level, the trust level, your supervisors and named clinical supervisors, and of course, most importantly, your trainees. If you make it really clear what SDT is about, and we will have these slides available for you, and there's stuff, as I say, on the website that will be coming this week about self-development time. There's stuff on the NHS Employers website, and I think if you make it really clear about what it should be used for, and as I've already mentioned, stuff it shouldn't be used for, then hopefully you wouldn't have any problems. But again, I would just reflect back to you that it is work, and perhaps where there is a repeated problem that somebody is misusing their self-development time, then I would say it would be no different to what would happen if they weren't turning up for work. But I think like most things where there is good communication, where it's clear from the outset what the use of self-development time is, and it's all clear to all parties, then I would hope that situation won't arise. We've had some questions about documentation around self-development time. As we've already mentioned, it would be good at initial meetings to discuss with their educational supervisor and clinical supervisor about self-development time, when it'll be, how it'll be, and the sorts of things to use it for. But I don't think you necessarily need to keep an absolute log of what they do in the self-development time. But I guess it will raise questions towards the end if someone is very behind with their e-portfolio, whether they have had self-development time and what it's been used for. And as with most things in foundation program training, where it works well, where there's a good dialogue between supervisors, between trainees, between foundation program directors and the admin staff at the trust, then these things can be sorted out. So ensuring that your trainees have good channels of communication, where you are very clear, as we've already said at the outset, for what the self-development time should be all about, then I suspect you won't come in to too many problems. The portfolio, of course, there's lots of effectively free space under either educational meetings or something like it, where a trainee can keep a record of what they do on their self-development time if they want to. And of course, all these things are always worth reflecting on. We know that reflection has a bad name, but if we are going to practice evidence-based medicine and evidence-based education, there is an awful lot of evidence behind reflective writing and the benefit that it has for healthcare professionals, including doctors. So that might be a good way of articulating what people have done in the self-development time. Now, we've probably got time for one more question, if there is one. I'm just quickly looking at. And that's a helpful comment. So those who have facilitated inclusion of self-development time in North Devon, trauma orthopedics, it's rotated, it's pro rata less than full time where applicable, and it's great to hear that it helps facilitate work and reduce stress. And I'll give you my personal opinion that every single one of your organisation will have some sort of values or mission statement or something like that that says it values its staff. I believe that self-development time is a way for us to demonstrate that. It's all very well saying we value our staff. Well, no one's going to say we don't value our staff, but actually it's about what we do to show that rather than just saying it. And one of the reasons that I'm particularly a supporter of self-development time is that I do believe that it shows a way that we can value our foundation program doctors. The current cohorts of foundation doctors and their immediate predecessors have worked extraordinarily hard, as have all doctors and healthcare professionals during the COVID pandemic. But for those of us who are quite long in the tooth, it took enough to adapt to working during the pandemic. So imagine having to do that in your very first year as a doctor. And I think it's a real tribute to foundation doctors everywhere that they've got through and have helped so many patients during the COVID pandemic. I think it's a real tribute to their supervisors, both their named and educational clinical supervisors, but also more senior trainees who help them, our nursing colleagues who help them, all the senior doctors and nurses who've helped our foundation doctors to get through, and of course the trust admin staff around the foundation program who've been really very helpful to them as well. So we are very grateful for everything that people have done over the last year and a half to help foundation doctors during the COVID pandemic. I'll bring this now to a close. So I would like to thank Fatima in particular as a trainee for coming forward and giving her views, which I think is really valuable to hear and made some really good points. I'm pleased to say that Marie, the other trainee who works less full time and was going to speak this afternoon, is going to record her little bit of a talk, and we will have that available to you. I'd like to really thank Tony for taking the time and for answering the questions and particularly for his work around the curriculum, which, as I say, I think is a fantastic piece of work. I'd like to thank all the MERP team for organising this webinar and the hard work they put into organising it. Just to remind you that the recording will be available on the YouTube website as shown on this slide here. There's a number of other links both to the UKFPO, to the Medical Education Reform Team, MERP, and to where our foundation pages will be. Your foundation schools are a fantastic source of wisdom, experience and advice. So if you have any specific queries to your local issues, then please get hold of your foundation school. The people who work in those is a great group of people. So I'd like to finish by thanking you very much for your time. I hope it's been informative, and as I mentioned earlier, we're very grateful for your help with foundation programme training in England. Thanks very much indeed. Goodbye.